it's special for me to be here. I know, I mean, so many of the faculty in this group. I work with so many folks, the Prostate Cancer Foundation, um, study sections. Of course, I've known Peter since, I don't know, I guess 2003. It may surprise you to know that Peter was the golden boy when I was a resident. I mean, that's shocker. Kind of just thought I want to be like him. Truly, and I, being in a great residency program like for us, University of Washington, it really did foster that, that sense of, I could be a surgeon scientist. See Peter and some other folks more senior to me that kind of navigated that path. That's for me, that really helped make me think, okay, I think I could do this. And so that is you're really one of the first people like Dan Lin, who just started our faculty, saying you go to MD Anderson and do what you've done. And a couple other folks kind of set the stage for, okay, this is a path that is viable. I also have to tell a quick story. So the first ever urology meeting I went to was Western Section AUA in, I think, 2006 in Hawaii. And I was, I gave a talk and I'm like super nervous and of course like all dressed up and gave my like 5-minute thing that I'd rehearsed a bunch of times, memorized, and gave the talk. And I sat down in the audience again afterwards, like, okay, I got through that. I survived. And like the next talk, up to the mic comes somebody who's like, kind of built, like blonde hair, like towel around his neck, and aloha shirt that like buttoned all the way down to the navel, and like asked us like really insightful question. I was just like, who the hell is that guy? Martin Gleed.
You had a big gold.
I should have. And so I was like, I'll never forget that. Like that was my first impression of you. Like, God, that is like that. Like I could never be like that. But that's how it's done. So it's I mean it's been amazing to go from kind of watching you and thinking, oh man, that's that's amazing what you've done and what you've built, and for me to be able to learn from that. It's really, I've kept a very close eye on this program for many years. Um, this talk is about diagnostic tests in localized prostate cancer, and something that I'm really interested in for a million reasons, from the translational science to the impact in the clinic to regulation. And I really wouldn't mind if you guys chime in as we go, because I've tried to understand like how this works in Canada, and it's of course it's totally convoluted in the U.S. I think it's pretty convoluted in Canada too. But I'll probably ask a few questions. Please, speak up at any point. So I kind of want to start with our NCCN guidelines. So these are in the U.S. the National Comprehensive Cancer Network guidelines that I think we rely on more than AUA guidelines. Do you guys use NCCN guidelines here a lot? Yeah. So if you look in 2024 and the prostate cancer guidelines for the principles of risk stratification, right? This is for a patient you're seeing newly in a clinic, and you're thinking, okay, we've got our usual stuff, Gleason grade and PSA, and we want to think about some additional testing. On here, let's see, is this cursor work? Is that visible? Maybe you see it there? No. Okay. Oh, you can't. Okay. It's over here. There's several gene expression classifiers. I'm going to talk about these: Decipher, Polaris, and what used to be called Oncotype, now is called the GPS test. There's artificial intelligence digital pathology platform called Artera. There's germline genetic testing, and then again for this, and then there's post prostatectomy tests, again calling out these several gene expression classifiers based on tissue. And I'll talk about those in more detail. But so like this was where we were as of December 2024, just several months ago. And principles of risk stratification, and then come basically January 2025, there was a big shift, and it actually had a big impact. So it narrowed these tools down to just two tests: that's the Decipher gene expression classifier and the Artera digital pathology AI test. I'll talk more about those in the newly diagnosed setting, and then post prostatectomy, just that Decipher gene expression classifier, tissue based gene expression classifier. And so again, these are the principles of risk stratification and biomarkers as they currently stand in prostate cancer. And I'm on the prostate cancer guideline panel, and we can talk more about like how this came to pass. But yeah, this is a localized. This is these are localized biomarkers. So I'm not going to be separate talk to talk about the kind of somatic testing and germline testing and advanced things. And so then the question is, okay, where, right, that's the past, which is really not that distant. This is where we are today. And then where are we going in the future? I'll tell you, like, the prostate cancer guideline panel, NCCN panel, is meeting again in a couple of weeks. And this is going to be a big agenda item because it's incredibly controversial, right? We have to think about, what is, and you guys in your system, folks think about this from different angles, but we're the same questions, like what's really impactful, what's driving outcomes, what's driving decisions, what's cost effective. These are all expensive tests, roughly $5,000 or so a test. So when a patient comes in the clinic, right, newly diagnosed prostate cancer patient, of course, I think three big questions that we hear a lot is, how bad is my cancer? That sets the stage, and it's usually Gleason score and PSA and volume and all that. It's, well, how do you know? As we kind of go through those usual things. And then a really common question that we hear, maybe you guys don't hear quite as often, is, I've read about this test, Decipher, Polaris, Oncotype. Would that be helpful in my situation? You hear that all the time, right? There's marketing, and people are on subreddits and you name it, learning about these tests, and they come and they want to ask. And so dialing back, just what are diagnostic tests? These are tests performed on blood, tissue, and urine, typically. Urine cytology counts, PSA, obviously these gene expression classifiers like Decipher, ctDNA, all diagnostic tests. And there's a lot of different settings that we use these tests: early detection like PSA, making a diagnosis, risk stratification. So we think about risk stratification typically as prognostic, right? We're trying to get a sense of how aggressive somebody's cancer is. It doesn't necessarily give us an indication of how to treat it, although we often make those management decisions based on prognosis, of course. But that's different than a predictive biomarker that might tell you that treatment A is better for this patient and treatment B is better for this patient. That would be a different type of biomarker. We don't really have those in localized prostate cancer. A holy grail would be something that told us that radiation would or won't be effective. For example, if surgery would be better than radiation or vice versa. And we have tests for survivorship and recurrence monitoring. And prostate cancer, of course, it's PSA, and bladder cancer, maybe we're all going to be using ctDNA in the coming years, for example. And then familial risk assessment. So germline genetic testing, really important in this space. Now, we often talk in the US about so-called LDTs, or laboratory developed tests. And I think the same terminology is used here from what I can tell. And these are specifically diagnostic tests produced in laboratories for use in their own facilities. And so this is kind of an end around from, you can develop a test and have it, send out kits, and people in their own pathology labs can run those kits. And those would need FDA approval in the US. But an end around that process is to run it in a central lab, in a single lab. And that, in the US, I'm talking about that kind of averts the need to go through the FDA currently. So turns out the scale of this is huge. So in the US, over 12,000 laboratories run LDTs, 3.3 billion tests run each year. At the University of Michigan, we run a ton of these tests, 6.8 million tests annually. It's a huge part of our business. At Mayo Clinic, it's even more massive, right? I mean, even we send, when we don't have ultrasensitive PSA in-house, we send that goes to Mayo if we were ultrasensitive PSA. So certain labs run a ton of these LDTs, and you can do that without having to go through kind of a lot of red tape. It turns out that there is regulation around this in the US, that these tests are considered in vitro diagnostic tests, which are specifically regulated by the FDA. But the FDA has exercised what's called enforcement discretion. And that means they just look the other way. They say, okay, we have the ability to regulate this, but we're not going to, because we don't have the bandwidth, and we're just going to really truly look the other way. Again, I think here these tests are not considered in vitro diagnostic tests. And I think kind of the premise is still the same, that LDTs in theory can exist without another layer of regulation. Correct me if I'm wrong. And so, we have a huge number of biomarkers that are available. This is kind of a swath of the prostate cancer disease continuum from early detection, diagnosis and staging, biochemical recurrence, all the way to advanced disease. And here are some of those tests that we have in advanced disease. But early detection with a ton of urine and blood biomarkers. I suspect not many of these are offered here. Then there's Polaris, the same tests here, diagnosis and staging, Polaris, GPS Decipher, and some artificial intelligence digital pathology tests. And if you look at all these markers that we have in the U.S., only a small number actually have gone through the FDA. So the vast majority of the biomarkers that we offer in the clinic that we talk about are not regulated by the FDA. And so they're run as specifically laboratory developed tests. So with that background, I want to talk about 3 different domains in the data that support these different domains of diagnostic testing in prostate cancer. Inherited cancer risk testing, germline genetic testing. Of course, we identify inherited mutations by saliva or blood. A bunch of different commercial labs offer these tests. It's important for cancer screening, prevention, testing of relatives when we identify a patient with one of these mutations like BRCA1 or 2, informs treatment and trials, particularly in advanced disease, but also trials like the GUNS trial that is your guys' trial here. Then there's these genomic tests, also known as gene expression classifiers or gene expression signatures. These use tissue from biopsy. These are the 3 tests, Decipher, Polaris, and GPS that I mentioned. We use them at this point for prognosis and risk stratification and theoretically to help us make management decisions. And then there are these digital pathology, artificial intelligence-based tests that take images from pathology slides. It can be biopsy, it can be prostatectomy. Use those images, use all the data that you get from those images. Don't really necessarily know exactly what information you're getting, but of course, like many machine learning algorithms, you put in enough data and enough of the input, enough of the outcome, and you can build models that are prognostic in this case. So I want to go through these one by one and kind of give you the current data to support the importance / relevance of these. So from an inherited cancer risk testing perspective, this is really important. We actually know that germline testing of prostate cancer patients is just incredibly underutilized. And it's somewhere around 1% of patients with prostate cancer undergo germline genetic testing. Really, really, really low. I forget the number of breast cancer, but it's like orders of magnitude higher. The rates of mutations between prostate cancer patients and breast cancer patients is really, really, really similar. So if you say, well, what percent of patients with localized prostate cancer have a BRCA1 mutation? It's roughly 0.5%. BRCA2 is 1%. ATM, which is another important DNA damage repair gene, also about 0.5%. Generally, these are more common in high grade and metastatic cancer. There are differences based on European versus African ancestry. A lot of attention was put on this about almost 10 years ago now when this group led by Colin Pritchard. I don't know, Alex, you're honest. I should have looked, but yeah, probably are. But you've done obviously a ton of work that's relevant to this. They identified that about 12% of men with metastatic cancer with metastatic prostate cancer had germline mutations, and the majority were in BRCA2, or almost half were in BRCA2. ATM is also important, BRCA1. So this was a big wake up moment for everybody. Alex probably figured this out many years before that, but this was a moment where the field said, okay, a lot of our patients have these mutations present, and that led to kind of an evolution in clinical guidelines. And the guidelines, NCCN guidelines are a little bit more intricate than this. And if you look at AUA guidelines, they're a little bit more involved, but I really think this is the big picture important take home rather than getting too deep in the weeds. What should we really remember? Patients with metastatic prostate cancer, patients with high risk prostate cancer, high risk localized prostate cancer should undergo germline genetic testing, or at least have that discussion, be offered it. Mostly they're not in general. And it's also recommended even for low and intermediate risk prostate cancer in the setting of a strong family history. And that can be a family history of prostate, breast, ovarian, breast cancer, prostate, breast, ovarian, colon cancer. I missed one, pancreatic. Yeah. So we have to think about family history for low and intermediate, but we actually don't even have to think about family history for patients with metastatic or high risk localized prostate cancer. Those patients really should be counseled about germline genetic testing. We tracked pretty substantial series of patients in our practice, and just said, okay, over the next couple of years of germline genetic testing in our clinics, what are we finding? And we just published this recently, but it actually found that there were a lot of mutations in localized prostate cancer patients, about roughly 11% with localized prostate cancer had germline genetic mutations present. They were pathogenic, they were clinically relevant, we think. Similar number metastatic. Why was it higher in localized? I think it's just sample size. I mean, we don't really think that the rate is higher in localized. There were actually, Michigan happens to have a ton of, like population-wise, a ton of high prevalence of mutations in CHEK2, which is a DNA damage repair gene that maybe not quite as relevant when we think about prostate cancer risk, when we think about response to some therapies. And so it turned out that our localized cohort was really enriched for this particular mutation in CHEK2. But really, I think the most meaningful mutations were pretty similar between localized and metastatic disease patients. And it underscores that we really shouldn't just be doing this in metastatic disease, but this is important for us, especially as urologists. We mostly just see localized prostate cancer patients, and we need to be having this discussion. So one kind of important caveat of germline genetic testing is that historic workflow has been to identify patients who need testing and then refer them to a genetic counselor to have that discussion, have initial counseling. Do you guys do that here, or do you guys counsel directly in clinic? Mm-hmm. Right. Yeah. Years. So then what happens? They just use weight. Yeah. So we don't have years to get into the cancer genetics clinics, but 6 to 9 months. And what we've found, I think others have, maybe you guys have seen the same, is that you have this discussion in clinic, like you really should undergo germline genetic testing. We think it's really important. I'm going to refer you to cancer genetics. And over half those patients never show up, because by the time it comes around, they're like, I don't even remember why. Like, I'm fine. I've had my surgery or radiation. I'm fine. And so it just wasn't happening. So we developed a pathway where the urologists and oncologists were doing the education in clinic. And so we kind of got everybody up to speed. It's not that hard. And there are like even videos online now that you can use to educate patients. It's a 3-minute discussion, 4-minute discussion. You do need to go through it, like why it's important, the risks, like knowing that in our study, about 10 to 20% of patients will have what's called a variant of uncertain significance, but kind of a gray area. We're not, it's like probably those are like probably okay mutations, but some small percentage are clinically important. We need to talk about protections around, which are mild and not as good as they should be, around impacting disability insurance and life insurance. And so they're important components of counseling, but it's not that like we're very capable of doing it. So we did this prospectively, but we did it on a study. So we 4 counseling patients, we enrolled them in this IRB approved protocol where we said, okay, we're going to test. We want to test, see how we're doing. We're kind of unrolling this in our urology and oncology clinics, and we enrolled a large number of patients, like we had 260 patients, and the main outcome was satisfaction with the counseling and kind of testing on their comprehension. Did they get the key points? And here, dark green and light green is completely satisfied and somewhat satisfied, and kind of highlighted the question on the bottom. In summary, how would you rate your satisfaction with the counseling? And virtually everybody was satisfied. So the take home here was, yeah, we can do this. And patients got the information that they needed. And so our pathways, we do the counseling, and then only 10% of our patients actually need the genetics referral. So instead of sending all these patients to cancer genetics, they can't handle that volume. We're whittling down to just the patients that actually need it. And those patients actually get prioritized in our system, right? We pick up a BRCA2 mutation, and we get the information back to the patient. We say, yeah, here's why it's important, and now I'm going to refer you to cancer genetics. They're going to talk to you more about this, and they're going to walk you through cascade testing with family members. And so that for us has been a really effective approach. Yeah. We have mainstream. Right. It's, then they're using their time effectively to the patients who actually need them. The risks of genetic testing are very, very low, right? We do need to educate patients. Some patients decline it very, very reasonably. They don't want the stress, the anxiety. Maybe they don't have family members and they don't want to worry about it for themselves. But right now it is something that we're not doing enough of as urologists, and we can really improve. Yeah, it goes that right, exactly. So it's going to go up. Yeah, and you do this, and you uncover these mutations, not infrequently, right? Just kind of at a pretty predictable rate. And when you find a BRCA2 mutation in these patients, you feel like you're doing something really important because maybe it impacts that patient, maybe not. But they got sister, they got daughter. It's a big deal for the family, and so that especially when we think about prevention opportunities for breast cancer, interventions that exist, breast and ovarian cancer for family members, it's really important. From an FDA standpoint, there are actually only a couple approvals for germline testing. One is the BRCA test by Myriad Genetics. This was like some of you may I don't know if this registered up here, but it was a big deal when Myriad tried to patent this particular gene, BRCA gene, which is very aggressive, and it was a good try, but it got overturned in the Supreme Court. But they do have FDA approval for this test. And then another company, Invitae, also just like a year or so ago, maybe 2 years ago, got FDA approval for their hereditary cancer test. That was just in November 2023. Turns out they just, like last year, they had a huge $1 billion loss. They filed Chapter 11. They just got bought by another company. So the point here is I guess FDA approval didn't really help them. They went through the process, and they actually just took on huge losses over time. For whatever, I'm not sure why they were so unsuccessful. It was actually the external lab that we were using. We were using Invitae primarily, and we switched to Tempus recently to do our germline testing because Invitae is now LabCorp and the services weren't as good. So next, I want to talk about these gene expression biomarkers. And the reason that these exist, and I'm sure many of you are very familiar with this. You may know Decipher was developed right here in Vancouver. I think spinoff, or it was a spinoff, or yeah. Vancouver is kind of the home of the main test. I'd say the main test that's currently in the guidelines. The reason why these tests were able to be developed is suddenly, kind of 10 plus years ago, the technology for getting quality RNA off of formalin-fixed paraffin-embedded tissue really improved. And so that allowed people to take these data sets that had tissue banked in the path lab from 10, 15, 20 years ago and then matched with outcomes that are present time. We need that much follow-up for prostate cancer. And they used those patient sets to then develop these different gene expression signatures. And technologies that are a little bit different between company and company. The signatures are totally different, but they all do the same thing. They're trying to basically predict aggressive disease versus non-aggressive disease, not trying to stratify based on prognosis. So when we think about the NCCN risk criteria, right, it ranges, right? It's like we have these bins, very low risk, low risk. I think we're going to get rid of very low risk imminently, by the way, but very low risk, favorable intermediate risk. Right, so those are the bins that we typically think of if we're thinking about the NCCN guidelines for prostate cancer. But we know that risk is a continuum, that there's a ton of overlap. There could be a low risk patient who's actually kind of behaving more like a favorable intermediate risk patient and vice versa. When we're trying to make key decisions in the clinic, we're trying to do a better job than just these kind of single bins and move our decisions one way or another. We can use standard criteria, like again, like percent pattern 4, we often use, or PSA density, and that moves us along this continuum. And these gene expression classifiers, in theory, could also be used to kind of move us one way or the other along this continuum of risk. But that none of them, by any stretch at this point, have data to say, okay, if you're high risk, then you need a certain treatment. Say low risk Decipher, low risk NCCN, but high risk Decipher. That we don't have data that says, well, the patient does better if you do something different based on that information. So again, three tests currently: Decipher, Genomic Prostate Score, Polaris. They all have like different score outputs. They were developed with different endpoints initially. Again, they really basically all are prognostic, trying to sort out aggressive versus non-aggressive disease. They all have different thresholds. Thresholds in this setting are, of course, completely arbitrary because what's like it's almost it's like PSA kind of, right? You pick a number to try to give people some context and try to understand on the report how to interpret the data, but risk is a continuum, and just like a patient with a 3.9 isn't really different from a patient with a PSA 4.1. The same thing with these tests, and this is an example of what the Decipher report looks like. They give you this illustration of the risk continuum. Score goes from 0 to 1, and they kind of give you these breakpoints between categories for low risk, intermediate risk, and high risk. Again, they're pretty arbitrary, but they do help you kind of try to contextualize what you're looking at. It gives you risk of metastasis at 5 and 10 years with treatment. I got to remember that. And it gives you risk of prostate cancer mortality with treatment and risk of adverse pathology at prostatectomy. So this would be an example of a high genomic risk patient. And then it also, again, tries to give you some context and says, okay, well, compared to other patients in this NCCN risk category, you can look at this and be like, oh, they really are like on the upper end. Like, this is not a lot of patients are out here. Most patients are down here. And there's tons of data for Decipher. You think so? Now thinking back to what drove the NCCN guidelines to change, Decipher at this point of those 3 tests is the only one that has data from RCTs. And there's no data from like really prospective RCT starting from start to going forward with Decipher run in real time, but they have data from historical RCTs. And again, that's what we can do because the technology can use bank samples. So in this case, it was RTOG 9601, which is a radiation plus or minus androgen deprivation therapy trial many, many years ago. So it's one of the key trials that supports the use of androgen deprivation therapy with radiation when people are undergoing salvage radiation. But it was used for here in a totally different context to say, okay, we have all that data from the trial. What happens if we run Decipher? And the answer is that patients, again, who had low, intermediate, and high risk Decipher had different cumulative incidence of prostate cancer specific mortality, meaning that it does sort out patients according to risk level. And that is, last year at least, what drove the NCCN guidelines is a decision was made to say, okay, all these markers, we're not sure exactly what to do. There are more coming. People can kind of develop their own homebrew test, put it on the market. And a decision was made that only those tests that have used an RCT to validate the assay are going to be included in the NCCN guidelines. What's the rationale for that? It's that's kind of, those are high quality data sets compared to say, like, let's go back and find all the prostatectomies that we can that are still in the path lab and test in that setting. So use of archived specimens for prospective RCT is what drove NCCN guidelines. And this to mention, many of you know Felix Fang, a really close friend and colleague, radiation oncologist, and just an insane mentor to a million people, including me, who passed away, in December, and I'm close with many of you guys too, I know. There's data, there is strong data for other classifiers. This is from the past study, which is the Prostate Cancer Active Surveillance Study, a many, like 15 plus year long running registry that has been really led by Dan Lin. You guys participate here, we participate, And it's been an amazing resource to develop, validate biomarkers. In this case, the question was, okay, can we look at patients on surveillance with now a lot of follow-up and see how one of these markers performs? In this case, the GPS test was measured in a subset of patients who were on surveillance, underwent prostatectomy, and the outcome was adverse pathology. And if you look, like in model 1, which was just adjusting for Gleason score, the GPS test was prognostic. It was associated with adverse pathology. In model 2, when you adjust for PSA density, it like just fell short of statistical significance. Do I think that means that the GPS test doesn't work? No, I think it was underpowered on, it was a 100-patient cohort, but it is like one of the data points that people say, well, I don't know, GPS hasn't really shown itself to be, totally convincingly prognostic in high quality data sets. We looked a number of years ago at the question of if you get a test, how does it actually impact management? And so many of you, some of you maybe are familiar with MUSIC, which is the Michigan Urological Surgery Improvement Collaborative. It's a statewide registry and quality improvement collaborative that encompasses all of Michigan, basically all of the urology practices. All of the urologists in Michigan contribute data, all prostate cancer patient data, to the central registry, and now stones and kidney cancer are also included. It's an amazing resource, and we could go back and look and say, okay, if among patients, in this case, 1,500 favorable risk prostate cancer patients who underwent GEC testing, and that was a subset of 320, we could say, okay, if they had a high test, did they go into treatment? If they had a low test, did they stay on surveillance? If they had no testing, what happened? And you can kind of see, and I think this is pretty representative of what happens when you actually use these tests in practice. So if somebody had a high test, rate of surveillance is shown there, it's 46%. You'd say, okay, wait, you have favorable risk prostate cancer, you have a high genomic risk score, so high risk, and nearly half are still undergoing surveillance. Like, why did you get the test then? Conversely, 76% with a below threshold test were on surveillance, which is pretty good, but still you've got 25% basically where the test was ordered, came back low, and they still underwent treatment, and then no testing was somewhere in the middle. And so I think this is a pretty good window into the fact that these tests do move the needle, but they're not like huge decision makers, right? They kind of move the needle a little bit, but a lot of times testing is ordered and then ignored. And I think one of the principles of medicine and testing, anything we order, it's like think about, don't order a test if you don't think you're going to use it, right? Think about before we order a test, what we're going to do with it, not after we order the test. And so we've really tried to dig in and understand this question of how these tests are used, how they impact management, and ultimately whether they impact outcomes. And we're doing this through several RCTs. And so this is G-MINOR, which is the Genomics in Michigan Impacting Observation or Radiation Trial. It's embedded within MUSIC. It's run at a number of these sites in the state. And it's completed accrual a bunch of years ago, enrolled patients after prostatectomy who were high risk for local recurrence PT3 disease, positive surgical margins, and who at the time we would consider for adjuvant radiation. And the randomization was to decipher testing or no decipher testing. And the initial question was, is there a difference in rates of adjuvant treatment, if you get decipher and it's high risk versus not getting decipher? And then the more important outcome is, okay, if you get testing, does it actually improve survival? Does it improve rates of recurrence, metastasis? And so we actually just published the first report on this. And so we recruited 356 patients, ended up with 163 who were the control, usual care, didn't undergo testing, 175 who underwent testing. And this is the main take home so far. So all we have so far is impact on treatment decisions. We don't yet have the biochemical recurrence and metastasis data, but really, I think that's, of course, what people really want to know. Like, did it improve outcomes? But what this is, so we sorted by high Capra S, which is those of you who don't know, basically a clinical nomogram wave of accounting for other clinical risk variables like PSA and grade, and low kappa S. You see as usual care, and then there's genomic classifier low and high. And so if you look in the high kappa S half of the figure, for example, so on the x-axis is adjuvant treatment probability. You can see that if a patient has a high genomic classifier score, they're more likely to undergo treatment than if they have a low genomic classifier score, and also if they're in the usual care arm. And the same holds in low kappa S patients. So the take home here is, yeah, sure enough, patients with high genomic classifier scores in the genomic arm were more likely to undergo treatment. People kind of behaved in line with what you might think. Yeah, I think the ship has sailed to a pretty large extent. I mean, um, those three key trials really did not have like really high risk patients. I mean, very few T3B node positive, like a Gleason 9 and 10. So I think there's still a question of like maybe the highest risk patients we could still consider adjuvant treatment for. But more importantly, I think the question here still holds. It's like if we look kind of at the bucket of postoperative treatment, and we'll include salvage treatment when we look at biochemical recurrence questions. That like does the hypothesis is, even in the using adjuvant therapy less era, it's that patients who get early radiation because they have a high genomic classifier score should do better if we're picking those patients appropriately. Most of those patients are going to recur anyway. Totally. But that should help because we'll find more metastases. That'll help with the endpoints. Yeah. Here. Yeah, it was allowed, but it's not used so much because it was about 2018, 2019 enrollment. So, but we're still collecting. The nice thing is we still are collecting data on all these patients. So as time has gone on, we'll see higher rates of metastasis with PSA recurrence. So that I think will help power the study. We also collect quality of life data. I think it's not too surprising. So urinary incontinence, urinary irritative score, sexual score. The genomic classifier arm and the usual care arm had identical quality of life. The reason I think this is important is if we're overusing Decipher, or because of Decipher we're overusing postoperative radiation, we might see an impact on these scores, but really we're not seeing any differences in quality of life between the two arms. Another kind of cool thing about music is we can look at contemporaneous patients who are not enrolled in the trial, because all of the patients with prostate cancer in the state are included within the registry. And one of the things that we always talk about in trials is, oh, we did this trial and then we implemented it in the real world, and the real world doesn't seem to behave like the trial. And so we can ask that actually in real time and say, well, are there differences between patients who were enrolled in the trial and patients who weren't enrolled in the trial? And here we're looking at treatment-free survival. So basically rates of secondary treatment, higher use of adjuvant therapy is lower. And so in the music matched cohort, actually the adjuvant treatment was used a lot more than on the trial. Why is that? I have no idea. But it speaks to how often we put people on trial and the care is somehow a little bit different than if patients aren't on trial. This work is driven by one of our awesome fellows, Patrick Lewicki. And we also looked at the divide between low risk and high risk Decipher. So there's low and high risk Decipher on G minor trial, which is the green and red. So there's that split, right? So high risk Decipher meant more treatment. And there's the same split in music non-trial patients, blue and yellow, but just like everything shifted down. So it's like the take home is still the same, that high risk Decipher did lead to more treatment, but the rates were totally different. Again, it's like, why does that happen in trials? I don't know. It's for another day. But it does. So we currently have an ongoing prospective trial called G Major, and this is really the similar question, but in newly diagnosed favorable risk prostate cancer. So these are patients who are not in the very low risk category, but they have more than 2 cores of grade group 1, or they have grade group to disease with a PSA less than 20, and they're randomized to a genomics and a non-genomics arm. This is a 900 patient trial. Here, the primary outcome is rates of surveillance at 2 years. The hypothesis is that the genomic tests are giving us more confidence to keep patients on surveillance. We'll see if that really bears out. And again, we're looking at all the things you'd want to look at: grade reclassification, and pathology, prostatectomy, biochemical recurrence. Here, we're including all three of those different tests, not just Decipher. So that's like a 900 patient trial. We're still 200 plus patients away from finishing that. Yeah, no, yeah, it's a really good question. I think those NCCN guidelines are going to be malleable in the coming years. So since it's on trial, we can still we're still getting all of these tests. Like, one of the questions is we think these are the trials that should inform the guidelines. And so from that angle, it's like, we got to keep using all these tests, and let's see if they all perform similarly. Let's see if maybe they all should be in the guidelines, maybe not. There's, another way to do these types of trials is to really dictate management. So this is a NRG trial called PREDICT-RT, where patients are stratified into based on Decipher score. Lower intermediate Decipher score patients have the intensification question of whether you can use just like shorter term ADT with radiation. This is in the localized high risk setting. And higher Decipher score patients, the question is, should apalutamide be added? So it's like a de-intensification question in the low Decipher set of patients and an intensification question in the high Decipher patients. That's also enrolling. I think it may be just completed with accrual. Personally, so most of my patients that are in this window where I might get Decipher, one of these tests, we get on a trial. But if they opt out of a trial, how do I use the test? I think they can be useful when we're really on the fence between surveillance and treatment, like a high volume grade group 1, a grade group 2 disease patient where we just maybe a younger patient, we just can't quite decide, and maybe we need another data point.
What percent of low-grade prostate cancer do you look at?
Yeah, we actually just published that yesterday or the day before. One of our fellows, Stephen Monda, showed so the rate of low-grade pathology prostatectomy has really dropped, both nationwide in the U.S. and within Michigan. And it's now, I forget the recent number, but it's 5 to 10%, really, really low. Yeah, it's gotten a lot better. Yeah. Also true, exactly. Also, right. That's 84%. I remember that number are of low risk or on surveillance. But then if you just look at the prostatectomy pathology, it's really rare to find grade group 1. And at least in music, a lot of the grade group 1s that were found were patients who were biopsy grade group 2 and downgraded. All right. Right, but this study was published in JAMA Oncology a day or two ago, and it also used SEER data. So there's some national data, and then also the trends were really encouraging. What about AI? I got this picture last year when I visited Fox Chase as a VP, and we're at the basketball game, and Allen Iverson walked by. I was like, oh, I need a picture. I'm using this forevermore when I talk about artificial intelligence. Like, hey, what about AI? So, right, this is, as I mentioned, and then you guys are doing a lot of work here in this space. And here the concept is, instead of looking at the genes, and we kind of know we have at least some hypotheses about what the genes mean, and maybe we can rationalize it. Here it's just feed the slides in, add some clinical data. And this is clinical data. This is the Artera platform we first published in 2022 on. Feed in the clinical data, feed in a whole heck of a lot of H&E images, do some fancy informatics that I'm sure a number of you could explain to me that I don't understand, and then then you get an AI score at the end, and it just learns from the clinical histopathology data without any slide annotations. And not surprisingly, it works pretty well. There have been a number of publications from Artera, just like the Decipher data. The Artera data has used prospective RCTs to validate all the findings. So that's what, again, for Artera, has pushed Artera into the clinical guidelines above these other tests. And here, this is the same thing, stratifying localized prostate cancer patients in a validation cohort based on distant metastasis risk, high, intermediate, and low risk. Multimodal AI, the MMAI, the Artera AI platform. And it, just like study after study in the pre-prostatectomy space has shown this, we've now gotten access to two big RTOG, radiation oncology RCTs. One of them is that same 9601 trial that I showed before. The other is the 0534 SPORT trial. These are salvage therapy trials, asking the question, kind of like Decipher as maybe an opportunity to be used post-prostatectomy. Should Artera be something we should be considering post-prostatectomy? Does it work to stratify based on risk? And so pretty large study. The take home, unsurprisingly, was, yeah, it kind of looks like it works pretty well. All of these endpoints, distant meds, prostate cancer specific mortality, overall survival, a high Artera score was bad, and in a very statistically significant way. Kind of interesting at the same time is this question of like, well, can you use this type of information to tell us whether we should or should not be using androgen deprivation therapy? That would be more of a predictive signature. This is ADT along with salvage radiation, a really an important question. And so here, if you look in the low Artera group, the radiation alone and radiation plus hormone therapy curves are right on top of each other, right? So it's red and blue, like low risk, meaning the hormone patients who got hormone therapy in randomized trial, all like post hoc retrospective analyses of patients who got hormone therapy didn't seem to do any better if they were Artera low. I think that's why the punchline is I think it's interesting. I mean, right. So let's see over time. So then you see the spread with high risk, but the interaction P is 0.3. So it's not statistically significant, but I do think it's interesting. I mean, if it is event driven, we're trying to prevent events. If there aren't events to prevent, then why are we making decisions based on it, right? And this is out to 12 years. Yeah, but isn't that a good enough reason to tailor your decisions? Yeah. So here, I think the take home is that, like, there are advantages potentially to this platform. What are the advantages? I mean, as opposed to sending Decipher, say we got to like either send the tissue or take a punch and send it out. You could imagine a pretty easy workflow where it's like you've got a digital image, you upload it, it gets interpreted, it gets sent back. Theoretically, that could be like instantaneous. It could be at the time of diagnosis, right? There's a lot of possibilities that really streamline workflow with this kind of platform. The Artera is out, at least in the States, selling this, marketing it very heavily. And I would say, yeah, there's good data, but it's like, I think there needs to be more data collected. There's really no data in the earlier stage setting, like low risk, favorable risk, where we're thinking about surveillance. And so that's really where I think it's being marketed, because that's where maybe the current need is and the opportunity is, but there isn't data to support that yet. Of course, all these tests are only, anytime we're using, especially AI, machine learning techniques, you need really high quality data. So the last little piece of the talk is I want to go into something that I'm pretty interested in, which is like how are these like regulation these tests? Because again, I've tried to piece this together in Canada too, and it seems like in Canada these decisions are really made by like the health technology assessment and taking into account qualities, and the test can exist, but they're just not going to get paid for. And I think, and correct me if I'm wrong about that. And that's different. We're in the U.S. actually, these tests they go through a totally separate pathway and often get approved for reimbursement before they're in the guidelines, which is kind of a little bit backwards. And the bar to get like the reimbursement side is lower than you would expect. And so they're kind of, you end up with these tests that either payers are actually paying for that aren't in the guidelines, or that are being offered, and the company really just wants to drive up the market and kind of like make like a loss leader kind of thing, and they're offering the test for free, or like patients are, told it could be up to $5,000, but they never actually billed if their insurance doesn't pay it. We see that a ton with these biomarkers in the U.S. But what's happened over the last really 10 years is there's been a push for legislation in the U.S. to regulate this. And so there was something called the Valid Act that was really pushed forward in Congress in the U.S. That meant to bring all of these tests under the FDA. Which is a huge lift, to be a huge change. And there would be carve outs for like some grandfathering of tests because they couldn't make everybody go to the FDA from scratch. There would be some exceptions, but this was a big push. I mean, it was like mold like 2020 went back in 2021, 2023, another push. But ultimately, there was too much pushback, and a lot of the pushback actually was academic pathology labs because that's a huge part of academic pathology labs business. So they were one of the main sources of pushback that stopped this. And then in the fall of 2023, there was basically kind of what amounted to an executive order by the FDA. So kind of an administrative ruling where the FDA said, okay, that's it. You guys, like Congress couldn't figure out legislation. We're just gonna make a decision. It's not as robust as legislation, but they can do that. And they say, okay, we're gonna bring these tests under FDA regulation. And they like, it was a pretty aggressive rule. And they did a lot of communication around why the rule was needed. And there was huge controversy around it. Around that time, we actually wrote an editorial that we were kind of crafting right in real time. And like this came out like right as that rule actually was published. And this ended up being a really controversial perspective, like within academia to say, you know what, we really do need more regulation. It's like this is wild, wild west. And there are dangers of having tests that aren't really well regulated and patients don't know what to do. And so we need more guidance. Udit Singhal was the first author and led this. He's a former resident with us and fellow with us now on faculty, really outstanding. He's a surgeon scientist in development. It turns out, like I was, when I was trying to figure out what's going on here, there's a very similar perspective written about laboratory developed diagnostics in Canada like 5 years ago, like very, very similar points that we made in our editorial. So for me, I was like, oh, it's actually really, same issues here around like at least a perspective that, these tests are unregulated. They do need a little bit more regulation, and there needs to be a little more leadership put around or dedicated to the safety of these tests. The proponents of this rule were like patient groups and American Society for Clinical Oncology, insurers, a lot of the labs. Actually, opponents were laboratory groups, the American Medical Association, academic medical centers, health systems. So it was initially a proposed rule, then it was finalized in April 2024. There are a lot of nuances to it. Of course, there was a different administration, you may have noticed, in April 2024 than there is now. There was a big legal challenge, and it's like academic. There's an American Clinical Laboratory Association, and here Association for Molecular Pathology were suing the FDA. I'm pretty sure the University of Michigan was party to one of these lawsuits with the plaintiffs. So again, lots and lots of pushback from academia and pathologists against the rule. And actually, just a few weeks ago, federal judge vacated the rule, and so we came this far only to just have it pulled out. It could be appealed. Do we think that the current administration is going to be in favor of regulation and appeal this decision? Nobody really thinks so. So probably for the foreseeable future, all of that stuff is just done.
So here you have presentation.
Yeah. Yep. Yeah.
You don't then
like the validity.
that's
Exactly. Same here. So that's it. Exactly. So we think about analytic validity, like does the test what it's supposed, like if you say you're measuring PSA, are you actually measuring PSA in a reproducible way? Then clinical validity is like, does it predict outcomes that you would expect? Get the test, and higher PSA means more likely to have prostate cancer. And there's clinical utility, which is really like the G minor and G major trial, which is like if you get the test, does it provide you some useful information? And all of the regulation, same for you guys and us, is around analytic validity, which is like the bare bones, and almost none around the validity or utility. And so just to wrap up, like, where does that leave us? We're back, like, this is the current landscape I mentioned. I think it could be changing yearly for all I know. Again, I think these discussions at our next NCCN panel are going to be very interesting. And there continues to be a lot of debate on what really should be in the guidelines. These do, for us, have some impact on what payers will pay for. So they can kind of get, like, the companies can get these through to have some payment before they're in the guidelines. But then, like, once they're in the, like, mature enough in the guidelines have a big impact on what gets reimbursed. And in fact, like, Myriad stock plummeted like 15%, a huge company. But when this test was taken out of the guidelines, Polaris, their stock went way down, and it has stayed down. So the future, I think there's going to be widespread access to genomic and pathologic data. I really think like these technologies, they're going to be commoditized, right? There are a ton of platforms for digital pathology, artificial intelligence. Like merging that with genomics is pretty straightforward if you have the resources and access to tissue and data sets. Model performance will be driven by data set quality. I think that this is going to lead to a very decentralized diagnostic ecosystem, right? There's not just going to be a couple players. I think there's going to be lots of players. It's going to be probably tough to differentiate yourself commercially. And so that's where I think like the regulatory and ethical questions become really important around data, like who owns the data, who benefits from these tests, who should get the test. And just like the one thing I want to leave you with as the take home is from our ASCO guideline around molecular biomarkers published a few years ago, which is, we said, these assays are not recommended for routine use, but they should only be considered as a whole with routine clinical factors when they are likely to affect the clinical decision. So again, we only get tests when we think they might make a difference, and they do. And that is my family, my wife Wendy, Oliver with the Michigan hat, he's now 17, and Jacob in the hoodie, and that's Lake Michigan in like November. Thanks so much.